Hello, I'm Dr. Cesar J. Bravo from the Virginia Tech Healing Hand Fellowship Program, and I'll be discussing today physical examination of the injured brachial plexus in the adult patient. Plexus comes from the word braid, meaning a branching network. This branching network of peripheral nerves originate from the cervical spine and its respective interconnections, as is shown here. This makes examination of the extremity when injured a daunting task. Before we talk about the full examination of the brachial plexus, we really need to understand the spinal nerve anatomy. The spinal nerve anatomy basically arises from the dorsal sensory and ventral motor rootlets, as is shown here. The yellow is the dorsal sensory rootlets, and the ventral motor rootlets are shown here in green. The dorsal sensory ganglion in the dorsal root, as is shown here, highlighted in yellow. All these two rootlets come together and form the spinal nerve, which is as it exits into the spinal canal, the cervical spine. And these eventually, the spinal nerve, which is about a 1 centimeter in segment, which is highlighted in pink, that leads to the ventral ramus to the plexus, which is in purple, and the dorsal ramus, which leads to the paravertebral muscles. What we're going to be talking about is the brachial plexus, which is composed of the lower motor, of the ventral rami to the plexus. And it's important to know that the lower motor neuron is in the anterior horn and the spinal cord, and the lower sensory neuron is in the dorsal root ganglia. And these are important characteristics to note because we define our lesions in brachial plexus as pre and post-ganglionic, meaning after or before the dorsal root ganglia, and this does come into play in our reconstructive options. And this is a very important anatomy to know. One of the things also is that when we're examining the brachial plexus, it is a daunting task, as you can see from C5, C6, C7, C8, T1, that all these cervical nerve roots are a lot of fibers that come together. And, for example, the C5 root has 19,000 nerve fibers, the C6 has 25,000, C7 30,000 nerve fibers, C8 about 24,000, and T1 28,000. Of note, these all come together, form these peripheral nerves in the extremity. Likewise, when these are injured, it affects multiple parts of the extremity: shoulder, elbow, wrist, fingers, hand, and again, leading to why we have to be very specific in our clinical exam. A little bit about, continue with the anatomy. The roots, trunks, and divisions, they lie in the posterior triangle of the neck, whereas the cords lie in the axillary fossa. Cords are further divided into 5 major nerve branches of the upper extremity. Roots and trunks lie in the supraclavicular space. The divisions in itself are located behind or posterior to the clavicle, while the cords and branches lie below the clavicle and are kind of hidden between the pectoralis minor muscle, which is shown here. It's important to note that the name of the cords of the brachial plexus imply their relationship to the middle portion of the axillary artery. A little bit of difference of the adult exam, as we previously have with my partner, Dr. Peter discussed the pediatric brachial plexus. In the adult patient, the adult brachial plexus injury patient tends to emanate from a high energy mechanism. The adult tends to be more of what we call pre-ganglionic type injury, where it has a root avulsions. But in itself, I think it's more of a combination of root injuries, stretch injuries. The pediatric patient tends to have more of a post-ganglionic, which means that the roots are intact. The adult patient tends to have less chance of spontaneous recovery as compared to the pediatric patient. And the adult is difficult to reanimate the hand as compared to in the pediatric population, where getting hand function is our goal. In adults, we kind of break it in a simple way as we're teaching our fellows. But in a sense, when we talk about an upper brachial plexus injury, we tend to refer to a C5, C6 root involvement or an extended C5, C6, C7 extended. But mainly these patients, they cannot move the shoulder or bend the elbow, but the hand works. When we see a pan-plexus injury, or what it involves a complete plexus injury, at this, we know the extremity does not work. There's a flail extremity. The lower trunk tends to be involving spares a hand, but it's usually a hand that works but does not, but cannot bend the elbow. The patient cannot move the shoulder. And this is the extreme of the CAT1 as compared to the C5, C6 type injury. One of the things is that the injury to the brachial plexus, as previously mentioned, is a high energy mechanism. We have a combination of traction, compression forces acting on the brachial plexus, which are the primary means of the injury. Tractions do account for about 95% of the injuries in some series, and again, stating that it's a high energy mechanism. The most common injury tends to be a forceful neck flexion to the contralateral side, causing an upper trunk or upper root injury. Usually the ones that are seen here as shown in the picture here on the left, it's this forceful shoulder abduction, which tends to involve the lower plexus. And again, the force neck flexion to the contralateral side, either from a fall or with a helmet in a motorcycle accident, these are the ones that tend to involve the upper and middle trunk injuries. For in itself, as we get to the physical exam of the brachial plexus, it is most critical part of evaluating the patient with the brachial plexus injury. It is highly complex and can be very, really confusing. Specifically in patients with partial injuries, it can be difficult to discern the location of the injury. Manual motor testing, percussion at the roots, documenting both passive and active range of motion. This will actually record if the patient's getting better. Important to know that associated injuries of the contralateral side, patients may have pseudomeningeal cells that can push against the spinal cord on the opposite side, and also patients may have contralateral weakness. But again, manual muscle testing is the most important. It can be, and it's something that we use in our clinics, and it definitely can vary from patient evaluation by one physician to another in the clinical exam and how we grade it. And again, we'll go touch a little bit about it, but definitely the manual motor testing is very important to know at the roots. Always documenting sensation, pulses, as well as associated injuries, as previously noted that we can have contralateral weakness with pseudomeningeal cells. One of the things is what do we need to know, and what is the purpose of our physical exam? One is if we can localize where is the injury. Is it a type of avulsion type injury, or is it a rupture? If it's both, which usually in adults tends to be a combination of both, or is there a possibility of spontaneous recovery or not? This is what we use in our clinic. In a sense, we use the grading system for manual muscle testing, which is a modification of the British Medical Research Council grading. And for our practice, convention is stated as we cannot go higher in a grade in manual muscle testing unless the patient has full range of motion within the arc of passive range of motion against the resistance provided, no matter how strong the contraction is. Initial and serial examination and grading of all muscle groups of the upper extremity should be carried out. For example, unlike the biceps and the brachialis, which are innervated by C5, C6, the brachioradialis receives input from C7 as well. So in some patients with upper trunk injuries, these patients will have some elbow flexion that they produce using the brachioradialis at the elbow. And these are what we say, sometimes there are trick motions that the patient does not have the ability to fully bend their elbow, but subsequently use these residual muscles to compensate for that function loss. One of the things is we talked about the Steinler effect, and this is when the patient extends their wrists and fingers while pronating their forearms to enable further contraction of the flexor pronator mass and also augment the elbow. This is a part of what we want to be cognizant in the sense of when we're doing these physical exams of not only assessing the full range of motion in the arc of passive motion, but also looking for these gravity-induced motion, what we call trick motion, brachioradialis Steiner effect, or reverse Steiner effect. Important to know, as Bruce has stated, is the trick elbow motions that we can see in this article reference here. It's important to know that it does discuss some of the maneuvers that the patients will, at times, they'll use their brachioradialis to flex the elbow when actually they don't have any biceps or brachialis. A little bit about, as we move forward, we'll start with how do we discern patients that have injury to the nerve roots. These patients are said to have pre-ganglionic lesions, and in itself, this is an interspinal nerve injury, meaning it's a injury that does not have Wallerian degeneration. It's a spinal cord injury. The patient with a pre-ganglionic injury, again, is an interspinal injury. There's no Wallerian degeneration. The patient does not have a Tinel. The rhomboids and the serratus anteriors tend to be affected, and we'll talk a little bit about each specific exam. They may be phrenic nerve involvement if it involves the upper roots, specifically C3, C4, C5. That's the order in the phrenic nerve that can be affected, and patients will present with an elevated hemidiaphragm. Patients may present with a lower cord injury, such as a Horner's, or they may have a nerve conduction study which demonstrates an intact sensory nerve action potential, but the patient clinically will have no sensation in that extremity. We'll talk a little bit about pseudomeningocele, which we tend to see in pre-ganglionic type injuries, and these patients tend to have significant amount of neuropathic pain from the avulsion injury of the from the spinal cord. Again, CT myelogram does demonstrate the pseudomeningocele, and of note, these are injuries that tend to have a bad prognosis. A patient with a preganglionic injury will, or most of the time, will have supraclavicular swelling and tenderness. And again, if they involve that long thoracic nerve, they may have winging of the scapula. The neuropathic pain, or what we could refer to as the afferent pain, they'll have an insensate, painful extremity. If they involve lower root, they can have a Horner syndrome. They may have parascapular atrophy, or because of the paravertebral muscles are affected, they tend to shift away from injured side. And again, if the phrenic nerve's involvement is shown here, we may have an elevated hemidiaphragm in an inspirated chest X-ray. Inspirational chest X-ray. As we talk about each specific root injury, we'll go through some specific levels that are related with root injuries of the brachial plexus. We'll start with the C5 nerve root injury. It tends to involve the dorsal scapular nerve. The dorsal scapular nerve tends to provide function intervention for the rhomboids as well as the levator scapular muscles. And what happens when these muscles are affected, the scapula will tend to migrate from midline. In cases as that we can see where normal scapular alignment is in the midline, when the rhomboids and the levator scapular are involved, the scapula will tend to shift laterally. And this would be one of the ways for us to see on the clinical exam. In addition, when we see the cervical paraspinal muscles that are related to root level injury, specifically in the upper root injuries involving C5, C6, C7, one of the things is that the weak paraspinals will lead to the neck to shift away from the lesion due to their concurrent weakness. In addition, it's good to note that the C5 root origin of the dorsal scapular nerve is fairly predictable. It has been shown to originate approximately 95% of the time from the C5 root. In addition, when we're looking at a clinical exam in using EMG nerve conduction studies, one of the reasons to make sure that we get paraspinals is because when paraspinals are affected, they can be evaluated in the EMG, and that will correlate with specific root injuries in the brachial plexus. One of the ways to assess for the rhomboids when the C5 root is affected is by looking at lateralization of the scapular inspection, as previously stated. Also on the prone exam, you can have with the patient with the arm at the side, and when you ask them to forward flex their shoulder, if they're able to, you can palpate the firing of the rhomboid muscles. Another method is to ask the patient specifically to pinch the scapula between your fingers, and this may be a good way to assess the rhomboids. What we found in our clinic that the best way to assess the rhomboids is by patient putting the exam behind their back, kind of like a modified lift-off test, but we do resisted lifting of the arm, and at that point look specifically at the rhomboids, and you can actually see them firing as is shown here. As we move from the C5 root injury and we extend into the C5, C6, C7 nerve root injury that specifically affects the long thoracic, when this is affected, we tend to see the patients have what we know and disclose as medial scapular winging. Brachial plexus patients with long thoracic nerve involvement will have winging of the scapula. Winging examination is done with resisted forward flexion up to 30 degrees, since most patients with brachial plexus injuries are not able to do wall push-ups. The most efficient test for the serratus anterior involvement is protraction against resistance in the horizontal plane, and you need to make sure that the patient does not lunge forward during the exam. But again, this is what we're looking for, is the medial scapular winging. As the scapula, as we kind of resist that protraction, that scapula tends to ride off. Instead of riding protracted close to the chest wall, it'll go off that chest wall and create that medial scapular winging. A little bit about when we refer to winging. When we talk about medial winging, which tends to be involving this upper part here, is that the medial border of the scapula tends to come off when stressed, off the chest wall. And it leads to medial winging, which is problem with injury to the long thoracic nerve because of serratus anterior dysfunction. Lateral winging, as we can see here, is not necessarily the medial winging, but it's the whole scapular wall, the whole scapula is shifted laterally. This is associated not with spinal accessory nerve injury or injury to the dorsal scapular nerve, either by the rhomboids or the trapezius, and then leads to the lateral shifting of the scapula. And this is important to discern in our clinical exam. And again, the form of winging that we're mentioning here, either spinal accessory, rhomboids, or long thoracic, we tend to see with root type injuries to the brachial plexus. When examining the upper root injuries, specifically, we have to consider also the trapezius muscle. The trapezius muscle is innervated by the cranial nerve 11, the spinal accessory nerve, which also has sensory contributions of C2, C3, C4. So in upper root injuries, it can be affected. Of note, the trapezius has three parts, has an upper, middle, and lower part. And one of the things that we tend to see when the trapezius muscle is affected is that the shoulder will look drooped on that affected side. Normally, when the patient tries to abduct the arm, the scapula in a well-functioning trapezius tends to move laterally. What happens when the trapezius is affected, the scapula will move medially instead of laterally, and this is one of the ways that the shoulder is significantly affected in a trapezius deficient shoulder. We test again the upper part mainly of the trapezius muscle. We do this by shrugging of the shoulder with slight abduction to lower the contribution of the rhomboids, but also we do resisted arm abduction and lateral flexion of the arm, and this would also stimulate the trapezius muscle. Of note, this is how we're testing for the trapezius. We're basically asking to shrug, and this is for the lower border of the trapezius. We're doing somewhat of a resisted wall push-up that also assesses the lower part of the trapezius, and in the shrug would tends to basically test the upper part of the trapezius with resisted shrugging, as shown there. One of the things that can be subtle and must be at times you need a flashlight to assess is when we have involvement of the lower roots, specifically C8, T1 nerve roots. We tend to discuss, and sometimes in these patients, when they have these type of root avulsions in this level, they'll have what is known as a Horner syndrome. And Horner syndrome has been described as having ptosis, meiosis, and hydrosis. And this is usually related to disruption of the sympathetic ganglion, which is adjacent to the CAT1 roots. As we know, the T1 root is in proximity to the T1 sympathetic ganglion, and avulsion of this injury occurs frequently to both structures. And again, a constricted pupil is meiosis, a partial ptosis, which is a weak droopy eyelid, as is shown here. That again, this is a meiosis, a constricted pupil, and apparent anhidrosis is decreased sweating, and with apparent anophthalmos, which sometimes we refer to as the inset eyeball, as it kind of is pushed back compared to here where it would be protruding out, which is normal. And this is due to interruption of that sympathetic pathway, and it leads to these implications. And one of the things is of note is, if you can see here in our lower roots in the C8, T1, these branches right here are the sympathetic change. And this is, we've kind of removed the cervical spine here, and you can see actually the originator of the roots. But this slide really shows adequately the sympathetic change and why this can be affected and lead to that root Horner syndrome in the clinical exam, as is shown here. One of the things that we also look in our exam in the brachial plexus is assessing the pectoralis major. Why? Because this pectoralis major is one of those muscles that either sternal origin or clavicular origin. The lateral pectoral tends to be an upper part of the brachial plexus, which is the clavicular head. The medial pectoral tends to be C8T1, which involves the sternal head, which is a big portion of it. When the pec major is completely affected, we tend to see that with pant plexus injuries. But of note, we tend to use the medial pectoral nerve a lot in our practice with axillary nerve reconstruction, because usually in our upper trunk injuries, the lower portion of what we know as the medial pectoral nerve tends to be preserved, and it's something that we can use to reanimate muscles that are affected of the upper trunk, specifically for the axillary nerve. And one of the things that we tend to look in the clinical exam of the pectoralis major, one is looking at the girth of the pectoralis major, as you can see here, where there's less bulk of the pectoralis major as compared to this side. So that tells us this is a side where we have the pectoralis major dysfunction. Also look at the nipple line, where it tends to shift proximal as compared to where it normally would. And this is what is shown here on the right side. And again, this is a form of resisted kind of counter pressure with the two arms here that'll fire the pectoralis major as you do in your exam. And as we move to the examination of the post-ganglionic injury, I just want to make one last note to remember that when we have a pre-ganglionic avulsion type injury, as is shown in the picture here, the patient will have an insensate extremity, but in nerve conduction study, the sensory nerve action potential will be intact because the sensory neuron is in the dorsal root ganglia and is still in continuity. One of the things as we discuss post-ganglionic lesions is, as we move forward from pre-ganglionic lesions, is that the post-ganglionic lesion is potentially repairable. There's capability of regeneration. It's a peripheral type nerve injury, has better prognosis than pre-ganglionic lesions. EMGs tend to show positive intervention up to the cervical paraspinal muscles. In a sense, what we're able to do with these lesions, in addition to what we're going to discuss here in the clinical exam, but the main treatment of differentiator, which are the ones that we need to repair or ones that we need to observe, are only through surgical exploration, and this is when we're able to distinguish them if they're stretched, where they're possibly a recovery, or they're transected, where they won't recover aside from us doing a reconstructive procedure. As we move to the trunk nerve injuries, one of the things is a trunk injury to the brachial plexus at the supraclavicular level can be imagined to have an inner workings of a trunk of a tree. The patient will present with multiple peripheral nerve involvement depending on topographical location of the injury. And this is defined as upper, middle, and lower trunk. And we'll refer to each part of the upper, middle, and lower trunk as the functional anatomy at the trunk level that correlates well with the clinical exam, and that's what we'll highlight. And again, these are the topographical functional anatomy as the trunk level as it's defined into the clinical exam, the functional anatomy. Most often, the functional anatomy at the trunk level, it tends to be where we have a physical exam that is varied in presentation depending on what area of the trunk, either C5, C6, C7, C8, or T1. C5 tends to be mainly shoulder contributions, C6 tends to be more elbow flexion, and we'll go to each of these specific points accordingly. But this leads to intraneural anatomy, and it's fairly varied, and within each, originating from the root level to the cord right here, or trunk level, each segment, each 1.5 centimeter segment of the intraneural anatomy changes. That's why the clinical exam, when it's affected here in the cord level, is completely different than when it's affected in the trunk level, and that's where the clinical exam, depending on the location, we just have to be very specific. The important difference of what we're talking about, the functional anatomy, and the key physical difference in the physical exam to the brachial plexus injury as compared to the peripheral nerve, is that the brachial plexus injury tends to be more complex. Why is that? That's with regards to the intraneural anatomy as previously shown in the previous slide. The muscle intervention from multiple spinal roots with variable contribution to different muscles. Sensory loss tends to be in a dermatomal pattern. This is different than in the peripheral nerve injury, where there's a wound location, there's a typical pattern of motor and sensory loss, as it can involve the radial nerve, the median nerve, the ulnar nerve. And again, these leads back to our functional anatomy as well as an intraneural anatomy as previously stated. Important to note dermatomes, so it's important for us to assess the extent of the root or trunk involvement or cord involvement. C5 tends to involve the lateral arm and forearm. C6 tends to be correlated with the thumb. C7 tends to have a dermatomal distribution over the middle finger. C8 over the small finger. T1 over the medial forearm. And again, this is one of the things that as we examine the patients that have involvement in these specific roots, C5, 6, 7, C8, T1, how each kind of cross relates to each other, and that leads to the clinical exam, for example, in an upper trunk, where it will involve the brachioradialis, but it also involves the supinator, but you still have preserved extensors because of the C7 contribution, that a C5, C6 injury does not tend to affect those extensors. So this is what we're going to be touching base with that. So functional anatomy, we'll start with the upper trunk. Tends to be associated with more likely shoulder involvement, because it tends to involve in the biggest portion the supraspinatus, the suprascapular nerve. And that tends to see what we see in C5 type injury. How do we examine the C5 arm function, which is linked to the C5 root of the brachial plexus? We examine for shoulder abduction, which is deltoid, axillary nerve, and it comes from the posterior cord, posterior division of the upper trunk, leading to C5 root. And again, this is our suprascapular nerve coming off the C5 of the upper trunk and the axillary nerve as previously stated. And again, you follow the contribution from C5, C6, posterior cord leading to the axillary nerve. So this tends to affect our shoulder function and with C5 involvement. For examination of the deltoid, it's important to know that it has three heads. It has an anterior deltoid, a middle deltoid, a posterior deltoid. One of the things that we recommend for examining is holding the arm at the sides and resisted, that's for the middle, and resisted forceful abduction, and that tends to assess the middle deltoid. We'll talk a little bit about the swallow-tail maneuver, which tends to assess the posterior deltoid and internal rotation of the shoulder, and the extension lag test and abduction internal rotation testing. We'll show pictures of each. And again, manual testing assess the abduction strength. It's one way to detect for axillary nerve injury. And we'll talk about the abduction internal rotation test as described by Jamie Bergelli. When we see axillary nerve injury, it tends to have a global dysfunction. It tends to be a whole diffuse loss of that bulkiness of the deltoid, which tends to involve the posterior deltoid, middle deltoid, and anterior deltoid. One of the things that we, in our brachial plexus clinic, we test for shoulder extension bilaterally using the swallow-tail test. And a difference apparent in the swallow-tail test with elbow flexion, and the difference in performance is notable during abduction and internal rotation tests in the first 10% of the abduction due to rotation of the scapula. And this is the abduction and internal rotation test where you'll see the difference, and this is the side that's affected with the axillary nerve, as compared to here on this side and this is where it's affected accordingly. As axillary neuropathy, or what happens is we lose forward flexion and abduction and extension. And the swallow-tail test is described in 1995. Usually the deltoid paralysis was easily detectable because the patient inability to actively abduct the arm. However, full abduction of the arm may be possible in the presence of deltoid paralysis because of the action of the supraspinatus tendon along with the rotation of the scapula. The muscles that play a role in shoulder extension include the deltoid, latissimus dorsi, long head of the triceps, teres major, infraspinatus, and trapezius. As such, the physical exam can be daunting, and that's where the swallow-tail test seems to help us. And one of the things here is where we're doing the swallow-tail test, where we're examining for the posterior deltoid right here. And one of the modifications that we try to do is by flexing the elbow, we take the triceps extension out of the equation, and that is more specific for the posterior deltoid examination. And again, when the patient is bending forward slightly, the swallow-tail test with the elbow flex reduces the tricep participation in shoulder extension. As a result, a 20-degree extension lag relative to the normal side indicates a positive side. And one of the things is that the deltoid extension lag test, the examiner passively extends the shoulder and the patient is instructed to maintain the position actively, and extension lag is measured. Again, we're measuring here the posterior deltoid. One of the things that we use in our practice is modified, and again, we learned this from Dr. Jamie Bertel and his group, is the abduction and internal rotation test. Here, the patient is instructed to actively and maximally abduct the shoulder in internal rotation with the elbow flex. If there's a discrepancy in a position which is noted between the normal and the affected side, the examiner places the affected limb in maximal abduction in internal rotation, and the patient's asked to maintain this position of abduction. Any incapacity to maintain this position results in visible abduction lag, which indicates a positive test, as is shown here. In photographs, the range of abduction is measured using the angle created by the line passing along the thorax, as previously stated, in the arm. And here's an example of our patient using doing the swallow-tail test. As you can see, he can fully abduct his arm, but when we do the swallow-tail test, it's negative. He's not able to hold here on his left side. And the axillary nerve lesion on the left side, he's able to perform that swallow-tail test. But note the extension lag of the left shoulder relative to the normal limb. And we're able to have said that despite paralysis of the deltoid, he has full passive abduction. And here it's a patient with an axillary nerve injury on the left side, as noted here. Shoulder extension was bilateral during the swallow-tail test. So this was a normal swallow-tail test. We were able to do the swallow-tail test with elbow flexion to diminish the triceps contribution. And you can see there's a lag on the left compared to the right. But the main difference is notable in the abduction internal rotation test, where this is normal and this is the affected side. So this is where this is important. That's why we go into detail when examining the axillary nerve in these different modalities of examination to use in your clinic. As we move from the axillary assessment, when it involves the suprascapular nerve, it tends to involve rotator cuff musculature. This tends to be C5, C6. Again, the suprascapular nerve emanates from the C5, C6 root. And testing is done in a standard manner. We use the empty can technique and resisted external rotation with the arm at the side. If the patient is able to abduct to 90 degrees, then internal rotation resistance is assessed and examine the teres minor, and if possible, abduction to 90 degrees and 30 degrees of forward flexion in the scapular plane. And we'll talk about each of these as specific exams for the rotator cuff. Of note, the shoulder abduction involves the suprascapular nerve, the upper trunk, the C5 root. And here are the tests that we tend to do. We're looking specifically for strength of our rotator cuffs. We do what we call the abduction external rotation resistance test, which assesses the supraspinatus and the infraspinatus. We examine for the subscapularis muscle, with resisted belly press test, as well as the liftoff exam. And one of the things with the subscapularis exam, which is assessed using resisted liftoff exam, as previously shown in the previous slide, with the elbow slightly flexed to diminish the triceps contribution. But we tend to preserve what we call the bear hug examination, which EMG studies shown that activates the subscapularis as well as the liftoff and the belly press test with minimal difficulty to the patient. While the latissimus and the pectoralis entails major action, the patient's active place the affected extremity on the opposite shoulder and flex the shoulder to 90 degrees and compress the opposite shoulder in a downward force. When it's positive, you'll be able to pull the arm off that position, and that'll demonstrate weakness of the arm of the suprascapularis muscle as compared to the upper extremity. So the liftoff exam, you resist the liftoff exam, which resists it's the backside, but the bear hug tests mainly the upper subscapularis tendon. And again, here we're showing a normal bear hug where we're trying to pull with the arm across. We can't do it. A positive, we're able to lift. The belly press, as you can see, the elbow lays behind the mid-axillary line. They're not able to bring that elbow forward. And here they are, so the subscapulary is intact, here is affected. In the liftoff test, the subscapulary is intact. You make sure they have to have a slight elbow bend to diminish the triceps function. And here they're not able to hold off that liftoff, and it would be affected or positive liftoff test with the subscapularis tendon ruptured here, as shown here. And again, the bear hug tends to examine mainly the upper part of the subscapularis tendon portion of the rotator cuff. As we continue with upper trunk anatomy, now we move from C5, which was mainly shoulder function, which we talked about. Now we go to the C6 upper trunk anatomy. And this, patients may present with weakness to the musculocutaneous nerve, which manifests as weakness of elbow flexion. CC deficiency will see mainly radial nerve involvement, which manifests as brachioradialis and supinator. It's important not to forget to assess your weakness of supination in the brachioradialis. And again, a C6 involvement tends to be more biceps and brachialis, as is shown in this diagram right here. And again, the biceps tends to be an elbow flexor and a supinator, as shown in this character. Arm function, again, is linked to the components of the brachial plexus. So elbow flexion and biceps tends to involve musculocutaneous nerve when it involves the lateral cord anterior division of the upper trunk C6 root. So when we have a C5, C6 injury, to wrap it up, let's have shoulder deficit. So involving the axillary and the suprascapular nerve. We have elbow flexion deficit because the musculocutaneous nerve is involved. And then we have sensory deficit in the C5, C6 sensory distribution. As we move to the functional anatomy of the middle trunk, that tends to extend into this part of the trunk. As you can see, this is mainly now radial nerve involvement, so we tend to have affect the triceps as well as wrist extension. And this demonstrates that examination of the triceps, examining the patient's supine, can aid in eliminating the gravity to confound the triceps assessment. And again, here in C7, we're talking about radial nerves, the radial nerve into the C7 contribution of the triceps. Wrist extension and wrist flexion, as previously stated here. So arm function linked to component of the brachial plexus, the triceps, radial nerve, posterior cord, posterior division of the middle trunk, C7 root. This leads to the exam. A patient that may have weakness of the triceps, they'll have what we call an extension, elbow extension deficit, and they'll have wrist and fingers extension deficit as well when it involves the radial nerve, as shown here in the pictures. And usually when we tend to have involvement of the C8, T1 trunks, they tend to involve C8 mainly finger flexors, T1 tends to involve the intrinsic muscles of the hand, and usually these are associated with avulsion injuries, as previously stated, excessive abduction, patient falling from a height, clutching to an object to save him or herself, such as this. Other causes are cervical rib or long metastasis in lower deep cervical lymph nodes, frequently associated with a pre-ganglionic injury and a Horner syndrome, as shown in our previous slides. And these lower lesions tend to have a poor prognosis. These lower lesions tend to involve the intrinsic hand function. Both median and ulnar nerves in the periphery involve both involvement of the medial cord, the lower trunk, and then the C8, T1 root. Typically, patients will have deficit of the small muscles, intrinsics of the hand, again innervated by the median and ulnar nerve. Then patients may present with a claw hand, which is held in extreme extension, unopposed wrist extensors, hyperextension of the MCP due to loss of hand intrinsic, and flexion of the IP joints due to loss of hand intrinsics, as is shown here in the ulnar nerve deficit hand. As we went through the physical exam, one of the things that, why and when do we use electrodiagnostic studies? One is to help us localize the lesion. One is to discern prognosis for recovery and guide us in the treatment, surgical treatment options, as well as check for availability of potential donors. Imaging that we tend to use in our clinic, it varies from institution, but mainly CT mammogram detects about 95 sensitivity and 98 specificity of root avulsions. But now newer MRI techniques definitely have come into play, and we tend to use a combination of both. But again, this is surgeon and institutional dependent. Don't forget the associated injuries. We tend to see associated injuries with these brachial plexus patients that we need to assess. They sometimes may have rotator cuff injuries, as is shown 10% of the time. They may have spinal cord injuries in addition to the brachial plexus injured or root avulsed. They may have spinal accessory nerve injury, as previously stated, involving trapezius dysfunction, and this is a very important lesion not to miss because we tend to use this nerve for a big part of our reconstruction when upper root and trunk involvements are injured. Vascular injuries has been reported up to 20% in some series, and rib fractures associated with these. And this does come into play, the rib fracture, if we were using any intercostal nerves for reconstructive procedures. And of all the things that we've learned over the years is that you do have to have a team approach. I'm very fortunate to have my partner, Dr. Peter Appel, as well as our clinic staff, occupational therapy, our nurses in our multidisciplinary brachial plexus clinic, as this is definitely a team sport as we treat these patients, and they do not only require expertise surgically, but also as a team approach to address all the multifaceted needs that are of the complex patient with a brachial plexus injury, in order for them to receive the adequate care. And that's one of the things that in order to treat this injury, you do have to have a good team approach. And one of the things in our multidisciplinary clinic approach, we tend to involve our occupational physical therapists as well. Our goal is to maintain the range of motion, which is crucial in all phases of care. Our goals is to reconstruct elbow flexion, provide hand-to-mouth function, stabilize the shoulder to prevent subluxation, support power across the elbow, allow shoulder external rotation, perform later wrist extension, finger extension reconstruction. But main goal is for our team to be basically involved in all the phases of care. This is a fairly busy slide, but just to have it as a reference, it depends on the injury, the timing of injury. For specifically sharp injuries, we tend to explore early. Those that are close injuries, we do get the imaging is stated, and then we examine every 4 weeks. We do get a baseline, mostly EMG nerve conduction around the 3 months. And at this point, if there's no clinical or EMG improvement, it may require operative intervention. But examination of the EMG is improving. We do hold off on that. And then, at times, if we have stagnant improvement, that can lead to also surgical intervention. And then the delayed presentations or referrals to our clinic may lead to different treatment modalities, such as free muscle tendon transfers once over past the year mark. In general, nerve reconstruction, if it's going to be done, can be done within that operative window. We've definitely narrowed our window, but tends to be between 6 and 7 months. But following the injury, before the muscle atrophies is our goal. We also combine sometimes tendon transfer, and important to note that nerve reconstruction is time dependent. Tendon transfers do not have a time limit, and so you're able to do them later, and they do have faster results. You don't have to wait on the nerve recovery. And free muscle transfers are fairly complex. That's why you need a team approach, and these are usually the things that we do when we don't have the ability to provide nerve reconstructions to our patients. Of note, the mechanism of injury, remember that in brachial plexus injuries, high energy injuries tend to have a worse prognosis. The age, the younger the patient, the better the prognosis. And the type of nerve injury, exclusively sensory or motor nerves, have better functional recovery than mixed nerves. And the level of injury is important. As we know, a total brachial plexus palsy affects the C5 to T1. It's the worst prognosis. A total palsy leads to the entire flaccid arm affected sensory and motor components of the peripheral nerve system. So know your level of injury. Supraclavicular nerve lesion has worse prognosis than infraclavicular. The time of surgical intervention, you want to address it early if they're not recovering because of the fibrosis degeneration of target organs at the time of surgical intervention are related to poor prognosis. And of note, remember, assess the level of injury with the associated signs. Just to repeat, look for diaphragm paralysis, which is seen with upper C5 injury, root injury to the phrenic nerve. You may have medial scapular winging, such as long thoracic nerve involvement. You may have a Horner syndrome seen in lower root involvement. You may note what we call as a cervical scoliosis when the paravertebral muscles are involved. That also is seen in root injuries. And the normal moist skin sweating function is lost and tend to have dry, scaly skin. Sometimes these patients with pre-ganglionic injuries have this effect as well. Thank you for your time. I know this is a fairly daunting topic, but one of the things that we've learned in our multidisciplinary clinic is that education is the most powerful weapon, as Nelson Mandela stated, and as we can educate our peers, our fellows, our staff, our patients, and provide them most useful information so they can get the best treatment in these fairly difficult injuries. Hopefully this is very helpful. Thank you for your time.